Good morning. Welcome to this wonderful day and this event for Ross Greene. We're so grateful to be here today and to be in this beautiful place with everybody to share this time together. We're thrilled to have our graduate Ross Greene with us today visiting. He is here to be honored at Virginia Tech in our Hall of Distinction. And I'm just going to tell you a little bit about that honor because it's one of our most special honors for affiliates, friends, graduates of Virginia Tech. So in 2013, the Hall of Distinction was formed to honor alumni and friends of the college who have excelled in their professional careers, as well as their service and philanthropy to civic groups and the university itself. And we know Ross has been a tremendous provider of service to this university and to the field through all of his work that you're going to hear about today. So this symposium is our opportunity to honor him, to hear more about this area and this wonderful set of work that he has put together over the years to really help kids and help schools and help families with the collaborative and proactive solutions. So this symposium is called Collaborative Proactive Solutions, and it's an exploration of the past, present, and future of CPS. And so we have a variety of talks across the day from a range of implementations from the collaborative and proactive solutions. And it's just wonderful to be here and to honor him. And tonight he will receive that Hall of Distinction Award. So I'm going to present Rosanna Bro, who was very influential in nominating Ross for the Hall of Distinction. So she has come to the plate for her collaborator and her friend Ross. And so she's going to introduce him and talk more in detail about his work and how much he means to Virginia Tech. So thank you.
Thank you everyone for being here today, either on Zoom or live with us here in the beautiful South End Zone. It is my absolute pleasure to start off the symposium by introducing briefly again Dr. Ross Greene, who is the originator of the Collaborative and Proactive Solutions and founding director of the nonprofit Lives in the Balance, which just celebrated its 15th anniversary. As was mentioned, Dr. Greene is an alum of our clinical psychology program. And as part of this weekend of celebration for the Hall of Distinction, we wanted to organize the symposium just to go on a journey. Dr. Greene starting us off with the origins of CPS. And please at this time, just join me in giving a very warm welcome to Dr. Greene so he can provide an overview of the CPS model.
Hello, everybody. This is an honor, and I'm very flattered, and thank you. I would have been just happy being back in Blacksburg, where I haven't been in a while, and graduated over 35 years ago, so the place is a little different, just for those of you who have not been here for as long. Let me give you a brief intro to the CPS model. I'm assuming that this makes us go forward. No, it doesn't. I'm a Mac guy. Click on that. I'll just do the next. So I like to think of CPS as a hybrid model. There's a lot in it. And it starts with those social learning theory. Where else? But especially the work of Walter Mischel, who talked a lot about frustration tolerance and delay of gratification. And boy, does that make sense in the kids that I tend to specialize in. You may not hear me mention any diagnoses because these kids are referred to by a variety of different labels. The one that has become increasingly popular these days is pathological demand avoidance. That's the new oppositional defiant disorder, which is the new whatever. For me, oppositional behavior is a frustration response. Concerning behavior is a frustration response. And that's what Walter Mischel told us a very long time ago. Transactional models of development, huge. By the way, I should mention, it's all of these things that I was exposed to when I was here. So we might refer to this as a Virginia Tech model, a Virginia Tech Department of Psychology model, but certainly goodness of fit theory in particular influenced me because it became clear that when kids and parents were in conflict with each other, that was mostly an issue of incompatibility. And there's lots of different incompatibilities that can occur. Among the ones that are most prominent are when you place expectations on a kid that they can't meet and then push harder. Developmental psychopathology, huge. Family systems theory. I was a slight radical in my day as a clinical psych student. I had to get permission to take classes in the family therapy department. I don't think people were too enthusiastic about that, but I found that to be indispensable. Neuropsych, huge. Why was neuropsych huge? Because back 35 years ago, the research was just beginning to emerge that concerning behavior, a major contributor concerning behavior was skills or the lack of them. That's huge. And that body of research has just continued to grow. For me, the reason some kids have big frustration responses is because they're struggling with certain skills. Flexibility, adaptability, frustration tolerance, problem solving, emotion regulation. That the rest of the world is not so clear on that continues to baffle me, because a lot of kids still get mistreated because of obsolete ways of thinking about their concerning behavior. And then, of course, humanistic psychology. I don't know if I give Virginia Tech credit for that. That might be University of Florida, where I learned all about, especially when I studied Carl Rogers, this thing called empathy and how therapeutic it can be to a human being to just be listened to and to be heard. And that's just something I've been applying to kids ever since. See if I can get it to kid clip now. Yay. So here are the big shifts of the CPS model. And I've only listed 5, but there are more. First of all, we might refer to this as the psychology of antecedents, except that I don't call them antecedents. I call them unsolved problems. An unsolved problem is any expectation that a kid is having difficulty reliably meeting. Rewind the tape on the vast majority of frustration responses. What you will find is an expectation that a kid is having difficulty reliably meeting. Now, just to put it in common language, that means that the unsolved problem is early. And the frustration response, the concerning behavior, is late. So if we are primarily focused on behavior, we're primarily focused on what's late. And if we're modifying concerning behavior, we are modifying what's late. We don't want to be late. We want to be early. We want to push upstream. The unsolved problem is upstream. The behavior response to that unsolved problem and our response to that behavior is further downstream. When we're solving those problems, we are solving them collaboratively, not unilaterally. This is the kid has voice, the kid has agency model. And no, nobody loses authority by giving kids voice. You actually pick up authority by giving kids voice and engaging them in the process of solving the problems that are affecting their lives. This next one, number 3, is huge for me these days, just because I am so laser focused these days on all the things we teach caregivers, especially educators, to do once it's already late. We have had the wool pulled over our eyes on crisis prevention. De-escalating is not crisis prevention, it's crisis management. All kinds of things are crisis management, not crisis prevention. If this is anything, it's a crisis prevention model. Most of what we're teaching people, though, is what to do once it's already late, once it gets already becoming escalated. Ooh, drives me nuts. There is a mentality to this model. Don't be late. Excuse me. Kids do well if they can. We already covered don't be late. Kids do well if they can. This is the belief that if this kid could do well, this kid would do well. This kid would very much prefer to be doing well. That is in contrast to the belief that the kid is exhibiting concerning behavior for attention, to manipulate us, to coerce us into capitulating to their wishes, to test limits because they're unmotivated. That's not the language of this model. Kids do well if they can is the mentality of this model. Why would a kid not be doing well? Because they're struggling with certain skills. That explains their frustration response. And because there are expectations they're having difficulty meeting. There are unsolved problems. Going back to proactive here for a second, turns out that those unsolved problems can be identified proactively. And they can be solved proactively. Really no reason for us to be in the heat of the moment almost ever. And then finally, once again, this is repetitive, there's a major emphasis in this model on skills. And I already named what they are. Maladaptive behaviors are a frustration response. They are not an act of coercion. Just imagine how much that changes the lenses on what a kid is about when they are exhibiting concerning behavior. Ooh. So this is just the one slide I threw in there for the sequence of punitive exclusionary discipline. Everything in blue on here is early. In blue is the expectation the kid is having difficulty meeting. In red is everything that comes after that. In red, you're late. In blue, you're early. Blue is proactive. Blue is crisis prevention. Red is reactive. Crisis management. So the first red bubble, if a kid is having difficulty meeting an expectation, what is the prototypical adult first response? Push harder. Insist harder. With the assumption that pushing harder elicits better performance, which has actually not typically been my experience. You push a kid harder to meet an expectation, you already know they're going to have difficulty meeting. You are not going to elicit better performance. You are going to elicit a frustration response concerning behavior. So you can only imagine what I think of the grit literature, which tells us that to promote grit, there are two ingredients, promoting passion and promoting perseverance. So people have been putting a lot of energy into getting kids to persevere on expectations they're already having difficulty meeting. My sense is that that causes frustration responses. I have no problem with passion and perseverance. I just think there's a key word missing: problem solving. You're not going to develop grit without helping kids learn how to get past the hurdles that are getting in their way. Huge. But it's the missing P. What happens after you push a kid harder? The kid exhibits concerning behavior, the frustration response. Notice the behavior is late. It's occurring well after the unsolved problem. And if the kid's concerning behavior is what I call unlucky, which I won't go into detail about, but big, dangerous, scary, externalizing. What have people been taught to do? De-escalate. That's rub double number 3. And when you're now very late. And when de-escalating doesn't work, what do we do next? We lay hands on the kid. Red bubble number 4. So a big part of the mission of Lives in the Balance is to get rid of those practices, They are, generally speaking, completely unnecessary and mostly a reflection of the fact that we are more focused on what we're going to do when it's already late than what we're going to do to keep ourselves from being late in the first place. Real quickly here, the CPS model basically consists of two main components. The first is an assessment piece, which is where we are identifying the skills that a kid is struggling with and the expectations a kid is having difficulty meeting. When you identify those ingredients up front, there's no reason to be late anymore. I often refer to skills and unsolved problems as the information that's been missing because people have been so focused on behavior. The skills part helps people get the right lenses on. Skills are the reason this kid is struggling, not motivation. The unsolved problems give us a different target of intervention. Expectations, not the behaviors that are being caused by them. And then, of course, those problems are going to get solved collaboratively and proactively. So, what we've also done in this model is we've established 3 options for handling unsolved problems. This is a very nice shorthand for thinking about how we are currently handling a kid's unmet expectations and how we might choose to handle them instead. Those 3 options are called Plan A, Plan B, and Plan C. Plan A is where you're solving the problem unilaterally. And when we're implementing this model, Plan A is pretty much gone. Not because we're allergic to it, but because you don't need it anymore. What you're doing instead is solving that same problem collaboratively. And then Plan C, which is huge, is where you are putting a particular expectation on hold, at least for now. Why would you do that? Number one, lots of kids with concerning behaviors have a boatload of unsolved problems. You're not going to be able to solve them all at once. So you're going to have to prioritize. That's one reason you would use Plan C. Another reason you would use Plan C is because of this thing that we call expectation management. Expectation management basically says, don't put expectations on kids if you already know they can't meet them. That's just going to cause concerning behavior and all that comes after that. But in education settings in particular, where we have put mammoth amounts of pressure on educators to teach to the test, and where job security is even dependent on test scores, we have all kinds of expectations being placed on kids that they can't meet. And we're wondering why, post-COVID in particular, there are astronomical reports of concerning behavior and really serious ones in schools. Stop putting expectations on kids they can't meet. You'll make a major dent. We often say if you're focused on expectation management, you will be far less focused on behavior management. And then there's one more reason that you would use Plan C, stabilization. Lots of kids are in a state of mind right now that they can't even meet any expectations. We just want them to show up at school. Just show up. We're going to stabilize the kid. Why would we put expectations on the kid that destabilize them further in the service of what? It makes no sense. And yet people do it all the time. Turns out that in a lot of schools, people are allergic to the idea of managing their expectations. All right. I think this is the last slide. Not bad. How do you solve a problem collaboratively? Here's the technology. As a human being, part of me is kind of sorry that we have to actually lay it out for people. It just tells us we haven't had much practice. But there are basically 3 steps. They are called the empathy step, the define about concern step, and the invitation step. The empathy step is where you are gathering information from the kid about what's making it hard for them to meet a particular expectation. We always tell adults to be prepared for surprises in the empathy step when we discover that what we thought was getting in the kid's way is not what's getting in the kid's way. We're always telling caregivers it's not your job to know, it's your job to know how to find out. And your number one source of information on what's making it hard for this kid to meet a particular expectation in this model is the kid. Define it all concern step is where the adult is entering their concern into consideration. The exact same concern that might previously have led them into plan A is now leading them into plan B. And then finally, the invitation. This is where kid and caregiver are collaborating on a solution. But a solution that has to meet two criteria. It's got to be realistic. Both parties have to be able to do what they're agreeing to do. And even more important than that, it's got to be mutually satisfactory. Meaning, the solution truly addresses the concerns of both parties. So I'll finish off by saying this. Here's what I've been saying a lot these days, and quite frankly, it's not just my work with thousands of kids at this point, but also world history, including current world history that bears me out on it. If a solution is not realistic and mutually satisfactory, I promise you, this problem is still unsolved. So what do you think? I think we should be teaching kids pretty much from the word go how to do that. Who's standing in the way? Most adults who haven't been trained. We're trying to do something about that. Thank you again for being here. That's CPS.
Thank you so much, Dr. Greene, for getting us started. And at this time, I'm going to introduce Dr. Jennifer or Jen Wolff, who is a professor of psychiatry and human behavior at the Warren Alpert Medical School of Brown University and a child psychologist at the Rhode Island and Bradley hospitals. Additionally, Dr. Wolff is a proud alumna of the clinical psychology doctoral program here at Virginia Tech. You're going to notice a theme for the first couple speakers. Dr. Wolff will be presenting on the original empirical support for CPS that which she collected with Dr. Greene at Massachusetts General Hospital. I will note that at this time, CPS was still referred to as collaborative problem solving prior to the name change back in 2008. And Dr. Wolff, you should be able to share your screen at this time.
Did that work? Good. Okay. All right. Good morning, everyone. It is a pleasure to be here today to talk about some of the exciting studies I had the pleasure of being a part of, and to honor Dr. Ross Greene, who played a pivotal role in shaping my career. So let me set the scene. This was at Mass General. This was a research group that had a lot of gens, too many gens for Ross, who decided to rename some of the gens in the group after characters from his Lost at School book. It was the early 2000s. The world had just survived Y2K. Ross had recently written The Explosive Child. I was a wide-eyed research assistant doing my best to keep up with a man who was equal parts brilliant, passionate, and thanks to Oprah, he was suddenly very in demand. In addition to helping with research, I also had the glamorous job of managing Ross's clinical schedule. And when families called, they were often thrilled at the idea of seeing the Dr. Greene until I had to tell them about the rather daunting wait list. And some of those families were undeterred. They would do anything to see Dr. Greene, and they did things that I thought would surely happen to all of us as psychologists. I remember one family hoping to boost their chances of seeing him. They shipped us 2 full crates of smoked meats from their barbecue company. And Ross, being the ethical psychologist that he is, declined the gift. Me, being the helpful research assistant, took care of it. And I ate the 2 crates of meat because science demands sacrifice. But the thing that really defined those early days was Ross's commitment to helping kids and families who were so often misunderstood. He brought not just intellectual rigor to the work, but deep compassion and fierce determination to do better by these children and families. And so today I get to revisit the original CPS studies, or the OG with RG. So we will rewind to the first pilot study. This was looking at the efficacy of CPS. We all know that parent training has decades of strong empirical support, and it works well for many families. But Ross had a hunch that we could do more than perfecting sticker charts and refining timeouts. And actually, Ross had more than a hunch. He had a theory that was grounded in years of sitting with the most challenging kids and families and really listening to what they had to say. To test the theory, Ross set up a head-to-head comparison of CPS versus traditional parent training. And in this pilot, Ross didn't just want to show that both treatments improved behavior, he also wanted to show how differently these two treatments worked. So one sought to improve compliance, the other worked to improve the things beneath those behaviors. So CPS was targeting the lagging skills, the unsolved problems, and the explosive moments. He wanted to know if CPS improved behavior and also provided something that helps families connect, understand each other better, and improve the pathways that were contributing to the explosive outbursts. The original study included 47 children with ODD. They also had a comorbid mood disorder. They were 4 to 12 years old, and they were randomly assigned to either CPS or parent training using Barclay's model. We can talk about the results here. So while both groups improved, CPS showed some really standout results. Kids in the CPS group demonstrated significant reductions in oppositional behavior as measured by the ODD rating scale. And not just at the end of treatment, but this was sustained through the 4-month follow-up. The effect sizes were large for CPS, and in many cases, they were even larger than those who received parent training. This was also evidenced on the therapist and parent completed CGIs, with 60% in the CPS group showing clinically significant improvement at 4-month follow-up, compared to 37% in the parent training group. Behavior change was only one part of the story. Parents in the CPS group also reported significant improvements in parenting stress, especially in areas like feeling more confident and better able to handle their child's distractibility, mood, and adaptability. We also saw gains in parent-child communication and limit setting. So we weren't just changing behavior, we were also improving relationships and reducing some of the stress along the way that came along with parenting some of these explosive children. There was another striking finding. At follow-up, 80% of kids in the CPS group were rated as having an excellent response to treatment, compared to just 44% in the parent training group. And that's a pretty big deal. And from this early study, we started to see that CPS could hold its own against a well-established treatment. And in many ways, it offered something even more than that. It offered a flexible, collaborative, skill-building model that targeted the underlying challenges and built stronger partnerships between kids and caregivers. The other study that I was a part of in the early days was one that took place on an inpatient unit up in Cambridge. This study was focused on the elimination of restraint and seclusion and reduction of injuries on an inpatient child psychiatry unit. So this is a study that I still talk about probably on a monthly basis, because folks still can't believe these results. Inpatient units, in my opinion, are the last frontier for empirically supported treatments. This is where folks often believe that we can't actually utilize empirically supported treatments, that the only focus should be to stabilize, but to stabilize without using the things that we know from empirically supported treatments. And folks are incredibly focused on the cost of inpatient hospitalization and doing things as quickly and as cheaply as they can without being open-minded to other ways of managing behaviors. Restraints and seclusions are the norm. These are things that happen daily on inpatient units, and it's an accepted way of managing behaviors for our sickest kids. So this study sought to reduce some of the explosive aggressive outbursts in children, to reduce restraints and seclusions, and to reduce patient and staff injuries on the inpatient unit. So part of what I talk about monthly when I'm talking about this study is getting the right people on the bus. And so part of making these changes and implementing different programs in schools and in hospitals and other settings is making sure that you have people who are willing to not accept that restraints and seclusions and going to battle to get compliance are the only way to do things. So this study started out with a change in unit leadership. This happened over the course of 12 months. So getting people on board who were willing to not accept that restraints and seclusions were the only way to do things. Getting people who were open to actually looking at what was contributing to the behaviors that were being observed on the inpatient unit and those things contributing to aggressive behaviors. There was a period of active questioning on unit policies and procedures, and then they prepared for implementing the CPS model, and then there was a 6-month period in which staff were trained in the CPS model. So this, hopefully you can see all right. This looks at 3-month periods over the course of about 15 months here. The first phase was the pre-implementation phase. So those first 3 bars, these are very high rates of restraints and seclusions that were on this unit. The second part is where we got the right people on the bus. So getting people who were not willing to accept this as the status quo, that were willing to look at things a little bit differently. And they were these interested parties who were able to convey the message that this was not an acceptable way of proceeding and that something needed to change. So then they started actually implementing CPS on the unit, getting trained and implementing this approach. And then they went down to having no mechanical restraints or seclusions after a period of time. We also saw that the staff and patient injuries decreased. So people get hurt when there are restraints and seclusions. The patients get hurt, the staff get hurt. There's also a lot of turnover on inpatient units because of the amount of injury and this intense environment. So we saw that as we were getting the right people on the bus, as folks were being trained and equipped, they were able to also reduce this, the injuries for both the patients and the staff. This is also a place where, when I'm talking about this study on our own inpatient unit, I will in addition to talking about kids doing well when they can, I often talk about how staff do well when they can. So I don't think that a lot of the staff want to be restraining and secluding kids. I don't think that they want to wrestle them to the ground, but they don't know another way of managing some of these things. And so when we are training staff, teachers, and other folks in another way to manage these behaviors, they feel more equipped, they're able to manage the behaviors, and they get hurt less and have more job satisfaction over time. So when we implemented CPS on this inpatient unit, It led to a near elimination of restraint and seclusion procedures on a previously high-use inpatient unit from 281 incidents at pre-training to just 1 incident during the 15-month follow-up. There were also significant reductions in staff and patient injuries, highlighting CPS's potential to improve safety and shift unit culture through collaborative, skill-focused care. So this brings us to the end of our trip through the OG studies with RG. These early CPS studies showed us that there's more than one way to help oppositional and affectively dysregulated kids, and that some of the most meaningful change doesn't come from sticker charts or timeouts, but from empathy, collaboration, and skill building. Across both outpatient and inpatient settings, CPS led to improvements in behavior, parenting stress, communication, and in one case, the near elimination of restraint and seclusion. More importantly, these studies laid the foundation for a paradigm shift, one that invites us to move from managing kids to understanding them, from compliance to compassion, and from reactivity to proactive partnerships. And Ross, I thank you for having the vision to ask, what if there's a better way? For your unwavering belief that kids do well if they can, and for inspiring me and so many others to build careers rooted in that belief. Thank you.
Thank you so much, Dr. Wolff. At this time, we'll bring up our next speaker, Dr. Matthew Jarrett, another distinguished alum of our clinical psychology program. Dr. Jarrett is currently an associate professor in the Department of Psychology at the University of Alabama. Dr. Jarrett will be presenting on the randomized control trial for ODD that was conducted here at Virginia Tech with Dr. Tom Olendick that also compared CPS to parent management training.
Hi, everyone. It's always so nice to come back here and visit. So it's really great to be here today. I'm going to be presenting on a randomized controlled trial for ODD that compared CPS to parent management training. I was a graduate student when this trial was conducted, and so I was actually a therapist in the CPS condition. So lots of great memories from being supervised by Ross and really thinking and learning about this new model. I still think back a lot to the families that I worked with. So I'm teaching an undergraduate class right now on developmental psychopathology. And so actually a couple of weeks ago, we were talking about oppositional behavior in kids. And so I presented the CPS approach and was able to even talk about some cases of kids that I work with when I was here. So lots of great memories from this trial. Right. That's the way to, sorry, I'm starting. Okay, so Ross and Jen have covered a lot of this already, so I'll kind of go through some of this faster. But when we think about oppositional defiant disorder, we're thinking about a recurrent pattern of developmentally inappropriate levels of negativistic, defiant, disobedient, hostile behaviors towards authority figures. We know parent management training, very well-established treatment that's been identified as well-established for a number of years, dating back to 2008, more recently in a 2024 review by Kaminsky and colleagues. So very well-established treatment for oppositional behavior. What are some limitations of PMC, though? We often see improvement, but symptoms often remain at the normative level after treatment. We often see also a lack of maintenance of treatment effects over time. We often see also high rates of attrition. So especially in low SES populations, sometimes we can see rates of attrition up to 50% for parent management training. Also, older, more aggressive youth may not benefit as much from parent management training. And as Ross, has mentioned in his past writings and today, PMT doesn't really fully address the reciprocal adult-child processes that give rise to oppositional behavior. So the current study, this is built upon that original pilot work that Jen Wolff just presented. This was a randomized controlled trial, 134 kids, 63 in the PMT condition, 60 in the CPS condition. And we also had a waitlist control condition, which you can see here at a small sample size, and I'll come back to that later, why that sample size is so small. But originally that waitlist control condition was planned for 6 weeks. And then we did assessments at post-treatment and 6-month follow-up. So a little bit longer follow-up than that original trial that was 4 months. Hypotheses, we hypothesized that the active treatments would perform better than the waitlist control condition. We hypothesized that the active treatments would not differ on treatment outcomes. We predicted that increasing age, male sex, and low SES would be associated with fewer treatment gains. And we also had some predictions about comorbid disorders. So we had predicted that comorbid ADHD would reduce positive treatment outcomes, and that comorbid anxiety would actually enhance treatment outcomes based on some past research. A little bit about the trial itself here. Took place here at Virginia Tech. We recruited via community referrals, local advertising. Youth had to be between the ages of 7 and 14. They had to meet full diagnostic criteria for ODD. And we had some exclusions, so couldn't meet criteria for conduct disorder, autism spectrum disorder, psychotic disorder, intellectual impairment, or any current suicidal or homicidal ideation. A little bit of an overview, get a sense of the sample here, 62% male, 84% white, average age between about 9 and 10, $66,000 for family income, predominantly 2-parent families, about half of parents being college educated, and the most common comorbid disorders were ADHD and anxiety disorders. So with the results, coming back to that waitlist control condition, that was ultimately discontinued because we found that the families that were participating were the kids were deteriorating pretty quickly, really showing lack of improvement. So those kids and families were reassigned to one of the active treatment conditions. In terms of attrition rates across the study, we define that as fewer than 6 treatment sessions attended. You can see here PMT and CPS, pretty similar rates of attrition, and below that 50%, upper limit of 50% that we sometimes see, especially in lower SES families. We also looked at treatment completers. So these were families that attended 7 or more treatment sessions. We had about 106 of those families. And on average, the treatment completers attended about 12 sessions with a range of 7 to 14 sessions. We did find that those who attended fewer than 7 sessions, out of variables we looked at, there was a lower level of parental education. So again, fits with the broader picture of what we know. Lower SES families often are more challenges with treatment engagement, higher dropout rates, things like that. These were intent to treat analyses. We did look at the waitlist group at post-treatment, but then collapsed that group into the active treatment conditions for the 6-month follow-up analyses. And in the analyses, we looked at time, so pre-treatment, post-treatment, 6-month follow-up, treatment condition, PMT versus CPS versus waitlist control, and then also the time by treatment interaction. And then in all of these analyses, we controlled for age and race ethnicity. So the results here, this is just looking at the clinician ratings. And for this, we were using the anxiety disorders interview schedule for children, where we come up with a clinical severity rating based on the clinician's view of the severity of the problem. This is looking at severity rating for ODD symptoms. We found that PMT and CPS both outperformed waitlist control at the immediate post-treatment. Pretty similar effect sizes here in terms of Cohen's d, large effect sizes for both PMT and CPS. At 6-month follow-up, we had a significant effective time. So across both conditions, kids continued to improve. We didn't see a treatment by time interaction though, so there was no difference between the two treatments in terms of follow-up here into the 6-month follow-up period. We also looked at a more global clinician rating, so this clinical global impression, so something that's not ODD specific. Similar story, PMT and CPS outperformed the waitlist control condition of post-treatment. Somewhat smaller effect sizes, but still, pretty good effect sizes there, similar across the two treatments. 6-month follow-up, significant effective time. Again, we see continued improvement into 6-month follow-up, but no treatment by time interaction. Okay, moving on to parent ratings. So this is looking at the parent perspective of how much these kids improved. This is parent-rated ODD symptoms. Again, we see PMT and CPS outperform the waitlist control. Large effect sizes, but not different between the two conditions. Significant effective time, no treatment by time interaction though. Similar story again for parent-rated aggression. PMT and CPS outperforming at waitlist control. Large effect sizes, maybe slightly larger on PMT, but not statistically different here. Significant effective time at 6-month follow-up, and no treatment by time interaction. Okay, so beyond symptoms, we also looked at consumer satisfaction here. So we asked families to rate how satisfied they were with the treatment. PMT and CPS, similar level of satisfaction at post-treatment. On average, both conditions were rated as parents and families being satisfied, with a range of being slightly satisfied to highly satisfied, and a similar level of satisfaction at 6-month follow-up. We also looked at treatment remission. So looking at going back to that interview where we have a clinician severity rating ranging from 0 to 8. We have a rating below 4 that's reflecting that we're in a subclinical range, so sort of below the diagnostic level. And we found that for both PMT and CPS, roughly about half of families here are reporting being in the subclinical range, no difference between the conditions. And then we also looked at that clinical global impression and defined that as if a family rated being much improved or very improved. And we saw, again, about roughly half reporting improvement in that range, no difference between conditions. We also looked at our predictor analyses. So we did find that the presence of an anxiety disorder actually predicted better symptom improvement on that clinician-rated ODD rating and also the clinician-rated global impression. But interesting, we didn't find that to be the case for parent-rated ODD or aggression. So this seemed to be an effect that was more specific to the clinician ratings, but not the parent ratings. And then for age, we found that older children did not improve as much as younger children on both clinician and parent-rated ODD symptoms. So the age effect was a little more robust in that we saw it across both parents and clinicians. And then finally, sex, race, ethnicity, SES, and ADHD were not significant predictors of treatment outcomes. Okay, so just to summarize, PMT and CPS were both performed better than the waitlist control condition. As I mentioned, none of the youth in the waitlist control condition improved. PMT and CPS were equally efficacious for youth with ODD, both in the short term and in the follow-up period, especially that 6-month follow-up was helpful here, so an even longer follow-up period than the original pilot work. And again, about 50% were subclinical at post-treatment as well. So we really saw some good clinically significant change here as well. Treatment being more effective for the younger children and those with the presence of comorbid anxiety. Again, though, that anxiety effect was only for clinicians. And so we still need to learn more about understanding that effect. Some limitations, small number of participants in that waitlist control condition, obviously, but for ethical reasons, we had to reassign those families. Predominantly white sample with approximately half college educated. So one of the questions is how well does this generalize to lower SES families that are likely to have lower rates of attendance, more challenges with treatment engagement, maybe potentially higher rates of attrition. So we need to learn more about generalizability. We also weren't able to explore moderators of treatment, so we weren't able to get into, does anxiety predict differential response to CPS versus PMT in this study? And then we also only had ratings of therapy adherence and not competence. So we had ratings to indicate whether clinicians were adhering to the protocol, the PMT components or the CPS components, but we didn't have more of a quality of implementation measure. All right, and lastly here, I'll just sort of recognize other folks who were involved with this study. And this was actually back from, I think this was maybe around dissertation defense time. And so I was bold enough to have the Tom coffee mug in my hand at his desk. It was a hostile takeover. So, as Tom would say, carry on. So we'll move on to the next talk here. Thank you.
So much, Dr. Jarrett. For our next set of speakers, we have a video recording all the way from Australia because it is currently 1 a.m. third time. And this is done by Dr. Anna Dedousis-Wallace, a senior clinical psychologist at the University of Technology, Sydney, and Dr. Rachael Murrihy, director of the Kidman Center at the University of Technology, Sydney. They will be presenting on the randomized control trial of CPS versus PMT that was conducted in Australia.
At the World Congress in Peru, where Professor Ollendeck shared findings from his... Good morning. Thanks for inviting us to be here at this conference. We feel very privileged to be here. My name is Rachael Murrihy, and this is Anna Dedousis-Wallace. We are researchers from the Kidman Centre at the University of Technology, working in Sydney, Australia. It was a pivotal conversation back in 2013 at the ABCT World Congress in Peru, where Professor Ollendeck shared findings from his recently completed RCT that really inspired and shaped this research. Up until that point, PMT had been the primary treatment for youth with behaviour problems, and although effective for many, it was not a universally successful treatment. Engagement can be challenging, and up to 40% of families undergoing PMT do not achieve satisfactory outcomes. So we aim to build on Professor Ollendeck's RCT findings, which showed that both PMT and CPS were equally effective in reducing oppositional defiant disorder in youth. And to do so, we explored the following research questions. Will the treatment outcomes seen in the Ollendeck et al. RCT be replicated within an applied clinical setting, a community setting, in an Australian population? Also, we can't assume that just because a treatment works, that it's acceptable to families. So the question our team posed was, is there a difference in the treatment acceptability of CPS versus PMT? Finally, we asked, can we improve outcomes for youth by matching client characteristics to treatment? So these studies form the basis of 2 PhD dissertations, and we should note here that both Professors Ollendeck and Greene also came on board as part of our PhD research team. Today we're presenting just a selected portion of the results. So if you're interested in more details of the publications, they will be posted on our last slide. The primary hypothesis for this study was that we expected that levels of oppositional behaviour in youth would decrease significantly and to an equal degree for both CPS and PMT conditions at post-treatment, which will be maintained until follow-up. Children in our study were aged between 7 to 14. Subjects were randomly assigned to one of 2 treatments, PMT or CPS, and families received up to 16 one-hour sessions of therapy. Assessment was conducted at baseline, post-intervention, and again at 6-month follow-up, and an intent to treat sample was used to manage missing data. For the treatment outcome analyses, we used hierarchical linear growth modelling and equivalence testing. For the predictor and moderator analyses, we used linear regressions and process. Now here we have the inclusion criteria and the exclusion criteria for the study. To be eligible for the study, as I mentioned, you needed to be 7 to 14 years and have a diagnosis of oppositional defiant disorder. You can also see the exclusion criteria listed here, and I'll bring your attention to the fact that ASD was excluded in this trial, and we're planning to do a trial in the near future examining CPS for autistic children. So if any researchers listening today have an interest in this area, please let us know. We'd like to connect. To measure treatment response, we used the semi-structured anxiety disorders interview schedule. We had 2 assessors separately interview the parent and the child. Parents also completed the disruptive behaviour disorder rating scale, and treatment response was further measured by the clinician-rated clinical global impression scale, particularly the severity scale. For treatment remission, we used the ADIS to determine if a child was diagnosis-free after treatment completion. We also measured overall improvement with the CGI improvement scale, which is much like a GAF scale. Lastly, the parent evaluation inventory was used to assess parents' acceptance of the intervention for their child. Let's take a look at the socio-demographics, and I've put up the Ollendek at our RCT here for comparison in the 3rd column. We had 133 completer families and analysed an ITT sample of 160 families. As expected, the majority of the sample were boys, and comorbidity was the rule rather than the exception. So these figures are confirming earlier research that behaviour problems do not occur in isolation and commonly occur in the presence of ADHD and anxiety. We also asked mothers and fathers about their cultural background, and in this study, mostly identified as Australian and Western European. Now I'm going to hand over to Anna, who's going to tell us about the results of the study.
Hey, now the results. And so our results were remarkably similar to those found in the Ollendek trial. And so we'll first look at the treatment response results. So we have the ADIS results here, and this is the clinician severity rating on the ODD component, which lists the ODD symptoms according to DSM. So the scale here ranges from 0 to 8, where 8 is low, where 0 is low and 8 is high, and 4 is the cutoff for clinical diagnosis. So you can see here that both groups started quite high, and this was classified as markedly disabled category. So did the treatments work? In short, yes. As you can see, there's a significant improvement in the ODD symptomology between pre and post for both groups, and both groups were around about the diagnostic cutoff at the end of treatment, and gains were maintained at 6-month follow-up. And we saw very similar results with our parent-rated scales of ODD symptoms, with no significant difference between the 2 groups. In terms of treatment remission, both groups were rated as being in the much improved category post-treatment, with no statistically significant differences between CPS and PMT. When answering the question, what was the percentage of young people with an ODD diagnosis after treatment finished, we saw similar results in both PMT and CPS. And while this may look like a difference between the 2 groups at a glance, they were also not statistically significant. The differences were not different. Ratings for treatment acceptability were also high for both treatments. So while it's great to see that both treatments work to an equivalent level, we still have approximately 50% of young people with a diagnosis of ODD after treatment has finished. So we therefore need to better understand how we can improve these outcomes for family. And this is exactly what the next phase of our study looked at by examining predictors and moderators of treatment outcome. So we examined initial problem severity, inconsistent discipline, parental attributions of child misbehaviour, as well as lagging skills. So just to go one step back and have a refresh as to what exactly we mean by moderators and predictors of treatment outcome. So moderator is a variable that is measured prior to the treatment assignment and implementation of treatment that, importantly, differentially predicts treatment outcomes. So moderator variables can identify subgroups of individuals for whom a specific treatment is more or less effective. Predictors is a variable measured prior to treatment assignment that is associated with treatment outcome regardless of treatment assignment, and they tell us for whom treatments are most effective. So in terms of our results for the predictors and moderators, so we found that all variables that we examined significantly predicted treatment outcome, but only child blame attributions was found to be a moderator. So you can see from the table that high levels of initial problem severity, lagging skills, and inconsistent discipline and child blame attributions all predicted poorer outcomes for both CPS and PMT. High levels of child blame attributions moderated treatment outcome, which was really great to see. And I think this is probably one of the most interesting findings because as a clinician, this can help guide us when choosing treatments for clients. So we found that mothers who are more likely to attribute their child's problematic behaviours to factors in the child did significantly poorer in PMT than in CPS at 6-month follow-up. So this result suggests that parents entering therapy who have child blame attributions and who might agree with statements such as, my child purposely tries to get me angry, my child is headstrong, my child that thinks he or she is the boss, they may benefit more from CPS than PMT. So what is the summary of our findings? So CPS and PMT have equivalent outcomes at post and 6-month follow-up. Both CPS and PMT were considered acceptable treatments. Initial severity of problem, lagging skills, and inconsistent discipline predicted poorer outcomes. However, they did not moderate treatment outcomes. And child blame attributions predicted and moderated treatment outcomes, suggesting that parents with high levels of child blame attributions before commencing treatment may benefit from engaging in CPS and PMT interventions. So as Rachael said earlier, we've only presented a small portion of our research in today's presentation. Please feel free to check out our publications if you'd like more information and details. And thank you again for inviting us to present today.
Enjoy the rest of the conference.
Yeah.
Right. So we have heard a lot about CPS as delivered by community clinical psychologists, as well in both training clinics and community clinics that are more traditional clinical settings. We are going to move away now with our next speaker, Dr. Daniel Hyson, an associate professor in the Department of Psychology at the University of Wisconsin-La Crosse, who will be speaking on CPS in schools.
Thank you, Rosanna. Like Rosanna said, my name is Dan Hyson. I wanted to start before I briefly introduce myself by congratulating Dr. Greene on the Hall of Distinction honor and Lives in the Balance on its 15th anniversary. I had not realized that we were reaching that milestone mark. I wanted to start, like I said, briefly introducing myself. Like Rosanna said, I am currently a faculty member in the school psychology graduate program at the University of Wisconsin-La Crosse. And in that day job right now, I'm training future school psychologists in the CPS model through having them read Lost and Found, practice using the assessment of skills and unsolved problems, and practice doing Plan Bs at their field experience sites during their training. Prior to that, I was a practicing school psychologist for 13 years, and that was actually the role within which I was exposed to Ross Greene's model. And it was through a parent of a child that I was working with. I was providing direct service to students who had emotional and behavior concerns within the elementary school that I was working at as a practicing school psychologist. And the father of a fifth grader that I was working with, who was on the autism spectrum and was diagnosed with ADHD, came into my office one day holding a copy of Explosive Child and said, "This is my child. You need to read it, and everyone in your school needs to read it." And I listened to parents. So I did. And I started to implement it with this student and other students that I was working with, and quickly came to realize something that those of you who have worked in schools realize as well, is if it's just me as the lone wolf using this model, I'm not going to get very far in changing the culture of the school. And so luckily, I had a very supportive principal who allowed us to do book studies on Explosive Child with other staff in the school. And so I did 2 parallel book studies on the Explosive Child with combination of teachers, administrators, paraprofessionals. And through those conversations, we really did change the way that we looked at kids with concerning behaviors in our school. So that was my initial exposure to the model, really changed the way that we worked with kids in the school, reinforced my gut feelings of how to support kids with concerning behaviors, and gave me a new language for talking about that. So I'm forever indebted to Dr. Greene for allowing me to have words to describe what I knew instinctually I wanted to do to support students, and to allowing me to provide then support to others in school settings in starting to try on this different lens. I'm currently, in addition to being a faculty member at University of Wisconsin-La Crosse in the school psychology program, I'm also a Lives in the Balance certified provider and trainer, and have really enjoyed over the last several years using that role to be able to work with folks, not just in La Crosse, but in other parts of the country, to be able to expose them to the model and coach them in using the model. So today I'm going to talk about CPS research currently under review for publication that has been done in the schools. Now, I should mention that I was not involved in conducting the research that I'm going to be sharing primarily within this time that I have, but I've had the privilege of working with Dr. Greene to be able to revise and resubmit these publications for these manuscripts for publication. And so those are in process under review at this time. Should also acknowledge that, as many of you in the room I'm sure know, research in schools has some limitations related as compared to research in clinical settings in terms of the controls that we can have over different variables, maybe the scope within which we can implement models. There are a lot of different variables that make that difficult to do within a school setting. So I'm going to share where we are right now, but acknowledging, as I'm sure Dr. Greene would, that this research is exciting, but still in process in terms of figuring out how to effectively implement CPS at a systems level within schools. So I want to briefly share 3 publications that I'm currently working with Dr. Greene on to submit for publication, and then one in particular I'll talk about in more detail. So one that we're working on is describes how CPS can be integrated into an already existing PBIS system. Something that came up here. I want to make sure that there's nothing that I need to do differently. Okay, I will follow up on that question later. So wanted to share that we are currently working on integrating an article that's integrating CPS into a PBIS system. It describes that process. That's one that's under review. We're also working on submitting an article that is documenting effectiveness of CPS in reducing discipline referrals and suspensions in school settings. But the one that I'm going to talk about in more detail in this time that I have is one that focuses on documenting the effectiveness of CPS in reducing the use of restraint and seclusion. So it really does build on the work that's been described already in this symposium about doing that same thing within clinical settings. So why was this project conducted? It really was conducted to be able to follow up on the documented effectiveness of CPS in reducing or eliminating restraint and seclusion in inpatient psychiatric facilities. That's, like I said, well documented, and that Dr. Wolff had talked about earlier. There are similar findings in schools anecdotally, but the formal documentation has been lacking, and that's one of the main focuses of this project, is to begin to fill that gap with documented effectiveness of what those of us implementing in the schools know is currently occurring with the impact of the model on the reduction of use of punitive discipline. So in this particular case, there was a concern about the frequent use of seclusion and restraint in 3 elementary school special education classrooms within a school district in Maine. And that led to this project looking at implementing CPS within those 3 specific classrooms, and then examining the impact on reduction of the use of seclusion and restraint. So CPS model was implemented in these classrooms beginning during the 2019-2020 school year. And there was professional development in CPS that was conducted with staff over a 4-month period during that school year that included training the lead teachers and associated staff in each classroom in implementation of CPS, modeling CPS for the staff with individual students, and providing staff with direct coaching in using CPS as they used it with individual students. And if I've got time at the end, I wanted to briefly note that in my experience in research and through this study, we have reinforced what a lot of us know is important to implementation, that it can't be a spray and pray approach to implementation where we just present a model to, in this case, especially school officials, and expect them then to implement it. We need to provide them with not only direct training, but also modeling and ongoing coaching to be able to increase the likelihood of fidelity of implementation long-term. And that's something that we saw in this study and something I've seen in work I've done in schools myself and with graduate students in our program. So, and this is also something that I think contributed to the effectiveness of the study and my experience with effectiveness of implementation within schools, given what I mentioned earlier about the difficulty of implementing large-scale systems change in schools, given the resources. Using existing school data collection systems to track restraints and conclusions was really important in this study, and not putting additional burden for data collection on the school district. Data was then tracked over the course of 3 years to evaluate the effectiveness of CPS implementation on the use of seclusion and restraint. And I'll briefly share a visual of the findings. So very dramatically, we saw a reduction in the use of seclusion and restraint from close to 100 incidents of seclusion in the pre-implementation period, that was 17-18 and 18-19, and between 20 and 40 incidents of restraint per year in each of these 3, across these 3 classrooms. It dropped dramatically, as you see, to following training and implementation to around 10 incidents of restraint and fewer than 20 incidents of seclusion. And what's also really notable is that it was maintained over the course of the following 3 years. So just a reminder, implementation occurred during 1920, and then during 2021, 21-22, and 22-23, you can see that reduction in the use of seclusion and restraint was notably maintained. And probably across all settings, but my experience has been, especially in school settings, that maintenance of change can be a particularly challenging thing to see, given all the other burdens that schools have for implementation of new initiatives, changes in staff. So that's something that's particularly admirable in this study. So what are some conclusions that we can draw from this research? We believe that the reduction in the use of seclusion and restraint was due to CPS helping adults engage in what Dr. Greene was referring to earlier as true crisis prevention rather than crisis management. For example, proactively identifying the problems that are causing students to escalate and proactively solving them, rather than focusing on concerning behaviors that signal the student is becoming escalated. So Dr. Greene talked about earlier that those behaviors are really meant to be just communication that the student's providing, that I'm having difficulty meeting your expectation, and that's late if we're intervening to address those behaviors. So this study, I think, highlights the fact that if we're going to reduce the use of seclusion and restraint, intervening earlier in true crisis prevention is really important. In addition, we believe that the reduction in the use of seclusion and restraint is due to CPS helping adults engage in true crisis prevention by recognizing that concerning behaviors and the problems that cause them are far more predictable than we had imagined. So I think when we look at just the behaviors, sometimes it can be difficult for adults in schools to see the patterns and to be able to figure out how to intervene surrounding those behaviors. That's because those are just the signals. That's the best way the kid has of communicating with us that they're having difficulty meeting expectations. But if we look at the underlying unsolved problems, the difficulty they're having meeting expectations, that's where the pattern becomes much more predictable. And so that's, I think, one of the reasons why we saw this significant reduction in seclusion and restraint in this study. And then lastly, recognizing that once those problems are solved or put on hold proactively, and here we're referring to the Plan C that Dr. Greene mentioned earlier, that we're not going to be able to solve all those problems at once. We need to prioritize them, put some on hold for now. So through solving the problems that are prioritized and putting on hold those that aren't priorities right now proactively, that's where we see this frequency of student escalations decrease. And then that means that we don't need to use restraint and seclusion as often. And that's what we saw in this study. So I wanted to end then by saying that some lessons that I learned through both working with Dr. Greene to publish these studies and through other work that I've done working with graduate students implementing researching CPS within schools is the importance of training, modeling, and coaching with those implementing within schools to ensure that they have the true resources to be able to implement CPS with fidelity. Because if we're not implementing CPS with fidelity to the way it was intended to be implemented, if we don't find an effect, of course, it's then not really sensical to say that CPS didn't work. But providing that training, modeling, and coaching can help empower those educational professionals within schools to be able to have the resources to implement CPS with fidelity. We then need to monitor that fidelity of implementation to ensure it's being implemented and to be able to track that and compare that to the findings we're having on outcomes. You may or may not be aware, but there are some great resources directly available for free on the CPS website that can help you with that. In the work that I've done in schools implementing CPS, we've relied really heavily on the ALSUP meeting checklist, or the ASUP meeting checklist, and the Plan B meeting checklist as great resources to be able to have fidelity checks that school professionals can use either as self-reports or having others observe them to really track that implementation and ensure that they're giving CPS a true shot to be effective by implementing with fidelity. So thank you so much. It was great to be a part of this. Really excited again that Dr. Greene is receiving this honor.
Thank you so much, Dr. Hyson. And for our final talk, myself and Anna Cash, the 2024-2025 Ross Greene CPS Fellow and Doctoral Candidate in our Clinical Science program, will be presenting on ongoing work, so we don't yet have results, of the Collaborative and Proactive Solutions Capacity Building Project in Ireland's Health Service Executive. This project is being led by Dr. Toby Sachensmeyer, and thanks to the introduction from Ross and Tom, I am serving as the lead researcher for. Let me get our screen set up. So again, just delighted to be a part of this amazing set of speakers, speaking to the outstanding legacy that CPS has had and where it's continuing to grow moving forwards. Kind of building on the last couple talks, where the CPS Ireland project is coming from is building on the progressing disability services model that has been implemented over the last decade to transform the way children and families receive health services across the country of Ireland. And really, the spirit behind this model is to try to remove barriers to access effective evidence-based services, partially by changing the way children and their families are receiving access to various health services. And specifically with this capacity building program, we're seeking to try to do a whole team interdisciplinary model to help providers, regardless of their background, understand why children are displaying these concerning behaviors and think about alternative ways, as we've heard throughout the symposium today, to help families of children address those lagging skills. And importantly, this is being done with children with a range of disabilities and behavioral concerns. As you heard in all of the RCTs, for example, autistic children were excluded. And this study has autistic children as well as children with intellectual disabilities and from a range of age who are being served by the CPS model. And CPS was chosen specifically for this capacity building project because it can be effectively implemented by clinical staff with a range of backgrounds under close training and supervision, as we heard with CPS in schools in the last talk, and as is happening in this project with the support of Dr. Greene throughout the training process. And so given this backdrop and kind of with these aims in mind, you see our specific goals. So trying to understand the effectiveness of CPS for supporting children and their families, specifically in the context of a community disability network team, or we'll call them CDNTs for short, throughout the rest of this talk within the Irish Health Service. We're also looking to explore, again, the effectiveness of a hybrid group versus individual model of teaching and coaching families. So typically CPS is implemented in a one-on-one setting, but for some of the organizations who are implementing CPS as part of this study, they're actually doing group-based trainings with families as well, and then having individual coaching sessions beyond that. And finally, trying to investigate the impact of this whole team interdisciplinary training. So really trying to hear from the clinical staff on what their experiences are with having a similar language and model to work from, regardless of if it's a psychologist, an OT, a PT, a social worker who's working with the families. And so briefly, I'm just going to go over the study designs and methods. This, you know, people here in the room, and many might not be familiar with the way the health service system is set up in Ireland, but basically there are two CHOs or community health organizations where this is being implemented, and they're specifically in the Galway region of Ireland, as well as the more rural areas of Clare, Limerick, and North Tipperary. I am butchering sayings of things today, I apologize. And so last year, a whole team CPS proficiency training took place with Dr. Greene for these two CHOs. And additionally, around 30 clinical staff and health service providers have completed the CPS certification training and are currently providing CPS to about 100 families throughout the community health organizations. One of the things that we're really interested in as you hear us talking about the different measures we'll be looking at today is that for various reasons, the uptake of CPS and implementation has been a lot higher in CHO3 than 2. And so we're going to be exploring through various different methodologies in our multi-method approach to try to understand from the staff, what about either the whole team training, factors related to the actual organization might have led to these differences to help inform how CPS training can be further implemented in a community setting moving forwards. Again, data collection is currently underway. We have a focus group next week, and it's anticipated that data collection will be finished this summer, and we'll be analyzing, disseminating this fall with a really exciting CPS Symposium workshop happening in Ireland for the first time in the fall. I will let Anna take it over at this point. She's going to describe the first 2 parts of this multi-method approach, which she is helping with as part of her CPS fellowship this year.
I'm going to try to not fall on these cords. Okay. So first is going to be our clinician survey, which we'll use to assess whether whole team CPS is acceptable, appropriate, and feasible for health service providers in supporting these children with behavioral concerns and their families as well, within the context of CD&Ts within the Irish Health Service Executive. Okay, so we expect that both the traditional and hybrid intervention using the CPS coaching model to support families to use CPS independently will be viewed as acceptable, appropriate, and feasible by at least 75% of clinicians based on their report on the AIM, IAM, and FIM. So this will be assessed based on the percentage that the clinicians choose either agree or completely agree on average across the 4 items on each measure, which we're going to get into next. Okay, so here you can see the 4 AIM items, which assesses the acceptability of CPS. I don't know how I'm moving. Okay, so the 4 AIM items are here. So this is going to be more of that acceptability of CPS. And these are going to be our 4 IAM items, which assess the appropriateness of CPS to address these child behavioral outcomes. So this is looking at more appropriateness. Whereas this last one here, the FIM, is looking at more at assessing how feasible CPS is for clinicians to implement with their clients and for the families to utilize as well. So additionally, a single item job burnout visual scale item was developed by Dr. Charles Carterwood here at VT, will be used to assess how burned out the clinicians feel and how much the CPS training affected their job burnout, from greatly decreased to greatly improved, with has not changed being the middle response. So a single job satisfaction question will also be asked to assess how satisfied the clinicians have felt with their job before the CPS training, and another 5-point scale item will be used to assess how much the CPS training affected their job satisfaction. Okay, so the reason why we are assessing these 2 items here is that the emotional demands inherent in work with children with disabilities who display challenging behaviors places these providers at particular risk of job strain. So specifically, health service providers, including social workers, psychologists, and occupational therapists, supporting children with disabilities and their families, generally experience high rates of stress and burnout, resulting in elevated employee turnover, heightened intentions to quit, discontentment, diminished work productivity, and increased absenteeism. So clinician surveys will be going out in April and May, once clinicians have had several months of time to be implementing CPS with families. So in addition to these quantitative surveys, clinicians are also being asked to participate in 90-minute focus groups to provide more detailed qualitative feedback on their experiences specifically with the CPS treatment, CPS training. and implementation of it with their clients and families. So the plan is to have 2 groups for those who went through proficiency training, one for West, one for Midwest, as we talked about earlier, and 3 focus groups for the certified individuals, with focus groups having at least 5 people each. So focus group questions will include general feedback on the positive and difficult or unhelpful aspects of the training, whether clinicians are implementing CPS in their clinical work, and if not, what's getting in the way of that. The way the training influenced the clinician's understanding of child behavior challenges and how to prevent or reduce such behaviors. And then how CPS has influenced their teamwork, team cohesiveness, and job satisfaction. So focus groups will be audio recorded for later transcription and inductive thematic coding to assess clinician understanding of preventing challenging behaviors, use of CPS in clinical work, and the benefits of the CPS training to the CDNTs.
All right, so the final part of data collection, in addition to collecting pre-post measures from the families who are receiving CPS, which again is about 100 families right now through one of those 2 CHOs, we also are collecting a range of naturally occurring data using many of the measures that you've heard introduced in the beginning of today's symposium, including things like the Plan B worksheets and the unsolved problems that they're addressing, how many they address, and perhaps most importantly, looking at when families are able to start independently implementing the CPS approach at home. So without needing the health service providers to be coaching them on it in those individual sessions. So beyond those naturally occurring data, I'll just briefly touch on some of these primary outcome measures that we're collecting from the parents. And this will be collected with all the families, regardless of if they're doing the traditional purely individual or the hybrid group individual model. And we're expecting that both of those are going to be viewed as effective models. So we'll be able to explore if there are stronger outcomes for the traditional versus hybrid approach. But we're expecting that both models will be viewed as effective, as indicated by our 3 primary outcome measures, which are parent report on the ASAP, or assessment of skills and unsolved problems, which we have specifically turned into a model that looks kind of similar to the impairment rating scale, or IRS, for people who are familiar with that, to kind of see how impairing those various unsolved problems are for their child in their daily life. Additionally, we'll be measuring family conflict using the conflict behavior questionnaire, as well as parental self-efficacy, so how comfortable they feel in their role as a parent in managing these concerning behaviors from their child. And so we've already started collecting the pre-data, and as families progress with solving these unsolved problems and moving to independently implementing CPS, we'll be collecting the post measures this spring and summer. And just for people who maybe have not seen the ASAP before, this just gives you a quick sense. So the ASAP has 16 unsolved problems. These are just the first 8, because otherwise it was not remotely readable. And with the IRS, this is where they're being rated. And excuse me, yes, I did say the wrong thing. These are not the unsolved problems. These are the lagging skills. And so these are the skills specifically being rated in terms of level of impairment that's caused by the skills not being present. CDQ, same thing with that family conflict measure. Parents are rating with 20 true false items whether or not these various issues or sources of conflict have occurred in the past 2 weeks. And again, you see the first 10 items here. And then finally, this is the brief parent self-efficacy scale that I mentioned, which just is 5 items. And as you can see, it talks about feeling like they can make an important difference in their child life, and feeling like in situations they know what to do when those concerning behaviors do arise. And so what we are planning to do this summer and fall is to use linear mixed models to examine, again, if the traditional versus hybrid CPS models result in lower levels of concerning behaviors and family conflict, as well as improving parent self-efficacy. And if we're not finding a significant difference between the individual versus hybrid models, we will also be able to analyze and potentially have the power to look at some of those predictors and moderators, as we heard in the Australian RCT. But if they're different with our sample size, this will probably end up being more exploratory to see potential predictors to help us inform if there are certain family characteristics, child characteristics, as well as organizational characteristics that might predict treatment response. And last but not least, we are also going to be hearing from the parents to not burden these families further. We have just a couple brief open-ended questions in a parent feedback questionnaire so that they can provide some feedback after engaging in CPS regarding how helpful CPS was for addressing these concerning behaviors, as well as improving the family's ability to solve problems together, and as a general satisfaction with CPS. And we also will be giving them the option through 3 open-ended questions to provide written responses on things that they liked, disliked, or wished might have been covered in CPS that wasn't. And we hope that this project can help inform future efforts then for utilizing CPS, both within Ireland, but also across the world with a range of more diverse health service providers, as well as potentially informing school-based care. And with that, I'm going to introduce our final speaker, who certainly does not need introduction. He has been mentioned, I think, 20 times today already. But I will be introducing Dr. Tom Olendick, who is a University Distinguished Professor Emeritus in Psychology here at Virginia Tech, and who was the mentor of Dr. Greene. He will be giving some closing remarks on CPS, as well as the impact Dr. Greene has had on the field.
All right. Well, thank you, folks, for being here, and Rosanna, all of your good work on getting this arranged, and to Jamie, of course, for facilitating it and having this all set up. And I'm not sure about you folks, but I thought we're having lunch at 11:30, and I see over here lunch is already set up, and I pretended to go to the bathroom before, but I actually went over and snuck a little morsel of food, and it's not too bad. And Ross tried to change that behavior in me many, many years ago. Ross, did you come here in 84 or 85? 84, okay. So I came in 1980. I was only a 4-year-old when he came. And so Ross and I kind of grew up together, and he made sure that we were on parallel paths as we did evolve. And indeed we were. Different kind of levels, if you will, but nonetheless, we collaboratively arranged and productively on a solution to what we wanted to work on. So in any event, Ross has just been an incredible fellow student. And I consider a fellow student because I learn as much from Ross as I do from he hopefully learns from me. And I should also add quickly that Jen Wolff was one of my students. She was Jen Goring at the time she came here. She came here and decided she had to have a different name to get away from the Goring and be more Wolff-like. And indeed, Jen has become that incredibly productive person. And so has Matt Jarrett, a former student here now at Alabama. And just to spread his good news, I just learned about 2 days ago he's been promoted to full professor at the University of Alabama. So where to go now? And Jimmy, come out, slip in that Rosanna Bro is becoming an associate professor in maybe a month or 2 or something like that, whenever it is. We'll find out. I think as many of you know, I retired in officially June 1 of 2021. That was at 12 a.m. on June 1, 2020. I know that because I was cut off of some of the university services. Honestly, that is true. And for the last 4 years, though, I've been kind of semi-retired. And as some of you, at least those of you at the CPS know, I have declared that this June 1, 12 a.m., as well as 12 p.m., I'm going to be retired. And we'll see what that holds for me. Now it's going to hold a lot of good stuff. But back to Ross and all this work, it's just incredible the amount of activity that has occurred. that this has led to. Just amazing. And the early studies, first of all, you probably gathered that some of the early trials done with Jen and Ross had better outcomes, if you will, for CPS. A little bit better than PMT, not always significantly different, but better. And in the trials that we've done, the randomized control trials, both in Australia and here, have shown parallel. And also that in both Australia and the US, I was kind of pleased to see, on the other hand, I wasn't, because we kind of suggested we do it, replicated in Australia. Back in 2013, I think that was in Peru, where we had that discussion. But in any event, the idea was to replicate it there in another country. So we get some, I thought almost exactly identical, the same findings in Peru as here. And so that was reassuring. Now, you might not be too comforted by the fact that only 50% or 55% of the youth improved. Sit on your seat gently, because this was really good news. It was, because you saw what happened in our trial, right? How many of the waitlist kids improved? 0% after 6 months. And we discontinued that with NIMH's permission because no one was improving. We could not justify having kids enrolled in the waitlist condition. So we did it only for 1 year. And then those kids, as I said, were reassigned to the PMT or CPS condition. And I don't really, there are 11 kids in that group, and I'm not quite sure now how they variably did, but there was no difference, as I recall, between those who had been in the waitlist and those who hadn't. But the waitlist parents were really distraught. They just couldn't be a part of a study in which they had to wait longer than that. And we had told them actually that after 6 months, they could potentially get involved in treatment if they still wanted to. So again, that was an IRB thing. Some of you may know I was the research integrity officer for Virginia Tech for a number of years. I'm sharing that with you now because I had to take some real slow caution in discontinuing the waitlist group, because that was unheard of. Dismantling of approved trial from NIMH, but NIMH agreed that that was permissible, acceptable, and actually plausible, that we were trying to revise that to some extent to do that. So in any event, don't be too dissatisfied with 50%. I also think I should add too, that sometimes people make a lot out of whether or not subjects are seen at a place like Virginia Tech or a place like in Australia, the Kidman Center in Sydney, or in psychiatric facilities, schools, etc. I would submit to you that some of the kids who come here are poorer off, if you will, than those who go to mental health clinics. We tend to get people who travel here. In our phobia trial, in fact, we have a study called Have Phobias Will Travel. Anyone remember that story that used to be that movie, Have Guns Will Travel? It used to be a TV program. Well, this one's Have Phobias Will Travel, had people coming from 600 miles away for treatment because they had severe phobias. Same here on this trial. Matt was one of the therapists at CPS. I don't recall, I know we had a catchment area of up to about an hour and a half to maybe 2 hours away. It wasn't Chicago or New York City like we have for some of our other trials, but nonetheless, we did have people coming from various places. And many of these kids were really severe. They had on the ATIS, as you might call 0 to 8, scores of 7 or so in terms of clinical severity. That's really severe. That means these kids aren't getting on very well. So again, they're not just kids who come to the Child Study Center. It's a nice facility. There's some nice decorations in there that Rosanna's now done to improve that for us. But nonetheless, these are kids who are suffering from. Now, what I want to do, rather than comment on each of them, because there's so much stuff, I could sit up here and talk for 2 hours, but I'm hungry. So I'm not going to do that. First of all, plus you folks too have heard some of this. You can read some of this. There's really some great studies that are out there now, probably 15 studies or so on CPS. And we've done from our group alone, probably 12 studies using CPS PMT. Some of them actually with Julie Dunsmore. Some of you here are the faculty remember her, a developmental faculty. And with Jordan Booker, whom some of you have done, Michelle Lee. Jordan is now a professor at University of Missouri. And Michelle worked with him as an undergraduate, and now she's here with us, so that longevity continues. But in any event, there's Patrick Booker et al., Julie Dunsmore et al., and others doing this, trying to look at different moderators and mediators potential. And what we too have come to the same conclusion that the Australians came to, in a sense, and that is that really where the kids seem to be lacking, and I would also say, by the way, the parents are lacking, is in emotion regulation skills. I know Rosanna Bro is an expert in that area and doing some good studies on that. But I would suggest to you that the emotion regulation is as poor in the parents as it is in the children. And the study that I want to see done in the future is one that involves only parents and looks at whether or not if you teach a parent how to be collaborative and proactively solving problems that are occurring, do you really need the child involved? And I think this is really, I didn't tell Ross was going to say this, but we can talk about this later and he'll get me, I know. But I think that's worth pursuing because look at what happens in the school setting. Teachers were trained how to interact with kids. In the other setting too, people were trained in how to do it and then they implemented it. And indeed in Ireland, that's going to happen to some extent. And how much of the children actually be involved, I assume they're going to be in treatment. But is that really going to be necessary? I think it's worth pursuing at least to determine if that would be the case. The other thing I think is really exciting now is that we're moving away a little bit from looking at targeted problems in a clinic setting solely. And we're moving out, as we just saw today, we, meaning Greene's approach, CPS approach, into community settings. And I'd love to see this done in Greene Mental Health Center, right across the street, well, way over here, across from the end of Virginia Tech, at least is the Community Health Center for this area. And over in Rhode, lots of centers there that could be using this in their work with children and adolescents. They again couldn't work it there, they could be worked in, and this could be done and to potentially evaluated for that purpose. Finally, I think also there's a lot of stuff going on. I was looking up recently on how much does restraint and seclusion still occur. So guess what I went to find that out? Google. And then my brother says, don't go to Google, Tom. You can't trust them. And I says, Brother Gary, I know you're a year older, but I'm a year wiser. He said, Tom, no, you're not. And he was right, of course. But I looked it up, and I think in 22, last week, there were 341,600 times seclusion and restraint were used in school settings. You hear that? 341,000. 341,000. That amounts to, by the way, and this was on there, it amounts to, what was, I thought I had this figured out here, that it's about 3 students every minute is being put into seclusion or restraint in the United States alone. And by the way, we use seclusion and restraint much more here in the US than they do in European countries, Australia, and other countries as well. So we really got to get out of the backward approach of it and become more progressive in how we handle this. And that's why I'm so excited to hear the school stuff, because I haven't actually read Heisen's work yet, and Ross's work on these studies are about to be published. So this is going to be fantastic to see how that works. And also with the attempt to implement it in Ireland is fantastic. And man, you're privileged to be one of these good scholars here and fellows. It's terrific, yeah. Well, let me end up there. I know some of the early work that Ross mentioned, some developmental psychopathology, and he and I have talked about that a lot. And you know how the main developmental psychopathology premise is what? There are multiple pathways to any one outcome, right? And any one pathway can result in multiple outcomes, right? So it's not A equals B equals C. These are all different pathways that occur. And we've been trying to work at that. And Ross, I remember talking about that. And when we talked about that, we talked about the ABCs, and he mentioned how his approach is kind of like applied behavioral analysis. So I know it's not to be construed that way, but in that much of it is antecedent is certainly true. I happened to be the president of ABCT in 1995, and I said, well, we got to go beyond that to the DEF. Let's get beyond the ABCs. We've been there for a long time. Development, ecology, and function, DEFs. Now, I didn't say DEI. Jamie, don't hold me that. I said DEF. That we need development, ecology, and function procedures here to really work with it. That's the whole model that Ross really embeds it. Well, let me just conclude by quoting 2 of my favorite people. One of them is Yogi Berra. Yogi Berra said one time, if you don't know where you're going to end up somewhere else. Okay? So know where you want to go, or you're going to end up somewhere else where you didn't intend to go. And another one, which I think is equally exciting, and my wife actually, Mary, helped me to find this, is from Alice's Adventures in Wonderland. Alice is saying at one point in time, Alice asked the Cheshire Cat, "Would you tell me, please, which way I go to from here?"